Good morning, respected faculty and dear delegates. I welcome all of you to this session of follow-up of a new high-risk newborn. We have Dr. Pankaj Garg, President-elect IIP Delhi, and who is coordinating this course, and Dr. NAVEEN Jain, Dr. Mamta Jaju. I request Dr. Pankaj Garg to please introduce Dr. NAVEEN Jain or say something about the session. Dr. NAVEEN Jain is a senior consultant at KIMS Health Institute at Trivandrum. He is editor of the Plaharty and Illingworth book, and he has been awarded Best Teacher Award by the National Board of Examinations. Dr. Mamta Jaju is head of the department at Chacha Nehru Bal Chikitsalaya, Delhi. She is presently president of Neonatology Forum Delhi chapter, and I welcome her and request her to please say something about today's topic.
Thank you, sir. Thank you, Dr. Ajay. So good morning, everyone. First of all, welcome you all to this wonderful eNeo Neonatology e-certificate course. And I like to introduce to our speaker, Dr. NAVEEN Jain, sir. So I think everyone knows about Dr. NAVEEN. He's the chief editor of our Southeast Asia Clohati issue, and he's one of the pioneer in developing the neurodevelopmental new follow-up course of the in the neonatology. So I request sir to start his session with the very interesting topic of follow-up of all high-risk neonates, because that's a very, very important thing which we are facing now because of the saving of a lot of preterm babies and high-risk babies. So the developmental follow-up and early stimulation therapy, and there are so many other things which we really need to take care, so that we'll have after survival a good baby should be there, a good child should be there. So that should be started from the NICU only. So I request Dr. NAVEEN Jain, sir, to please start the session.
Good morning to you all.
Good morning, sir.
Each one of you who is there in the Zoom meeting today has taken time off a valuable Sunday. Tomorrow is Doctor's Day, and we all know that it is not glorified that doctors are busier than many other professionals, or rather they can't plan a weekend if they want to. So if you have come on this weekend and joined this meeting, let's hope that eNeo and ourselves together can give some points for practice that will help families, babies, and as well as all of you clinicians, pediatricians in improving the care of these babies after they leave the NICU. So I'm just going to start my presentation.
Sir, is it possible to increase your mic volume?
I'll try that, sir. Actually, I hope it is heard better. I will try my best. Is it better now, sir?
Yeah. Thank you.
All right. So, all of you can see in this picture something we don't want to see in our OPD. When we see a baby like this, it is very distressing to the family. We know that the baby is having a future problems ahead, and there is double fear in our mind. One is this family is going to suffer a lot, and second fear is always fear of medico-legal issues also. Whether this family will blame us, blame an obstetrician for all this suffering that they're going to have. And this is not bad people. हम कहते हैं आज की patients खराब हो गए हैं, ऐसा नहीं है. If the outcome is so severe that they can see, जिसकी भी ओपी में जाएंगे वो कहेंगे डॉक्टर साहब इसका ब्रेन ठीक करने के लिए कोई दवाई है क्या, तो वी विल से नहीं, नथिंग कैन बी डन. अब तो कोई दवाई नहीं है इसके लिए, ब्रेन जब खत्म हो गया तो खत्म हो गया, इस तरह से बोलते हैं. तो पेरेंट्स गो इनटू मोर एंड मोर ग्लूम, सैडनेस, and this distress sometimes wins as medical legal issues. So as pediatricians, we have to remember one thing, कि if the baby is safe, baby अगर normal है, तो डॉक्टर को भी सब पूजा करते हैं, कोई उनको ब्लेम नहीं करेगा, कोई मेडिको लीगल केस नहीं करेगा. So the best way to remain safe is not just better documentation, it is not just better communication, it is not just having a good professional insurance जिससे कि केस हो जाए तो कोई हमारे लिए लड़ेगा, but it is best if we can prevent death or disability. So today we will try and learn a few things we can do together so that a baby and a family may not have these difficulties. So I will be only giving a few practice points on this Sunday morning. First practice point should be the most important one. All babies who leave the NICU must have a special notebook like these. रेड कलर वाला डेंजरस आउटकम का रिस्क है, हमें डर लग रहा है, वी आर वरीड दैट दिस बेबी may have problems. You may have another color book like green for a baby who has little lower risk. We have a book called as blue book in our unit. अगर वो blue book है तो we know this baby was in NICU. Normal small pink book है तो वो vaccination book जो है, it means the baby was a baby without risk factors. This flagging is so important that once the baby comes for follow-up, देखते ही you should be going back to the history कि इसको हमने special book दी क्यों थी? Was it hypoglycemia? Was it jaundice? क्या था इस baby को problem? And when we examine this baby in the OPD, after that, follow them up, ask them to come back, it would be based on these risk factors that we have documented in the book. तो अगर आपके पास हमारे जैसी डिजाइन बुक है which I show you and share with all of you today, वो है तो ठीक है if it is good. Otherwise, any notebook that is there which reminds you कि इस बच्चे को एक्स्ट्रा कुछ था जो हमें देखना है. Let us see, suppose the baby you have seen in the previous picture was born at 29 weeks. Antenatal steroids नहीं मिले थे इसको, Maxelf नहीं मिला था. And when he was referred to your nursery, he was already hypoglycemic at 20 sugar, symptomatic hypoglycemia, lethargic baby था. At the time of discharge, your resident or yourself made a discharge summary. उसमें या तो यह information छूट जाती है या लिखी हुई है तो बाद में याद नहीं रहती है. You see so many patients in the OPD, and later on when this family gets upset, you have no way to find out whether you missed something or this baby was born innately with risk factors like these mentioned below. But if you have marked it in a systematic way like this, the second point for learning today is have a risk chart like this. इस रिस्क चार्ट में क्या है कि हम लोगों ने ऐसे सारे पॉइंट्स लिख डाले हैं, इंक्लूड कर दिए हैं जिनमें बेबी को डेवलपमेंट के लिए रिस्क हो सकता है बाद में. Let us see an example. Prematurity 30 weeks है तो severe risk है, 30 to 32 moderate है, 33 to 34 mild risk है. Similarly, birth weight, fetal growth restriction, antenatal problems, not getting steroids, इस तरह से एक लिस्ट है. एंड वो लिस्ट डेली रूटीन पे हमें मार्क करनी है when we start seeing this baby. So if we don't mark in real time, then what will happen that we will forget this information. So please remember that this book is placed inside the NICU on the bedside of the baby at birth, at admission itself. And every time you face one of the risk factors, so at least once a week, you have to circle the risk factors in real time so that when the baby comes for follow-up, you will be able to clearly identify whether this baby had added risk. If this baby comes for follow-up and was in mild risk, after one checkup, I might say, you do not have to come all the distance. You can stay at your primary care service, maybe 100 kilometers from Delhi or wherever you're practicing. But if the baby was at severe risk, even if the baby looks well, we know that there is an increased risk later. We would call these babies back for follow-up again. So this is the second point which we would like to learn today. Is first one is flagging them for a risk factor. And the second one is this was the flagging risk by giving them a special book. Second, have a list of risk factors and circle the severity also. So any hypoglycemia is not as worrying as hypoglycemia, which is symptomatic with seizure, with lethargy. They have greater problems. So the first learning point for today is to recognize that some babies are at risk of disability when they go home. The great teacher, developmental specialist, Dr. Illingworth sir, has said that every day as pediatricians, parents, obstetricians, we are facing situations where we are worried that a baby may survive with risk of disability. What we are trying to do in our process of examination through the day is to find whether these have recovered from the injuries that have happened completely or they are surviving with some problems. This process has to have a clear signaling of severity of risk factors. The third point for safe baby, safe doctor is before going home, have a pre-discharge checklist. The largest number of medico-legal cases that are going on in India against newborn specialists include retina examination. And you did not create the ROP. And the problem is, if you did not write in the discharge summary, this is the date and this is the time when you have to come for ROP checkup. First checkup to ho gaya. Ophthalmologist, they met them. Now, the ophthalmologist told them come after 2 weeks. Family did not understand. They did not go back. Problem is, ophthalmologist is writing in his own notes, his own file, and that you may not check in your busy OPD. But if you have a structured format, which I'll show you, you will not miss these things. So before going home, your resident, yourself must have this checklist and say, do I still have a medical problem that I not resolved? A renal pelvis dilatation, a seizure disorder on medication. What milk? Remind them breast milk again. It is the only regenerative medicine that we still have. Medications which are going on, and also we have a table to say till which date you have to give, how many mLs you have to give. It is not important enough to just record the weight in head circumference. You have to mention whether it is tracking along the growth chart, whichever one you're using. Have a systematic physical examination before going home. Look for problems like wide fontanelle, tone abnormalities. Schedule or say whether you have completed the ROP and hearing screening and educated the parents for language milestones. You have done a neuro examination and necessary neuroimaging like ultrasound. You have given them advice for immunization, and very important, continue KMC and stimulation at home. You have to flag how well the parents are coping. Will they just follow up what you do? Or they are the kinds who may not come back. They have to be given guidance again. They have to be educated properly. Some of them may be very conscious, very nervous. To them, you may have to present the information differently. And we have a list of pre-discharge counseling sessions which must be taken and parents must have attended before they go home. This includes a basic life support class, danger signs, importance of follow-up, and so on. This format is our hospital format. You might choose another one of your own, where it clearly says when is your next date for ROP, where have you to report? When is the BERA, where do you have to come? Where is the audiology room? Where will development follow-up happen? And similarly, where are the lab tests going to be done? If you are a pay-from-pocket hospital, then can we tell them what is the expected cost when they come? So you may not have an existing printed format like that, doesn't matter. But have one page in the front part of the notebook left behind for giving the next appointment date so that the parent knows completely where and when to come. So this is very critical to plan the discharge. Mostly we write in the discharge summary, this is the date for coming. Parents don't come. People have tried to improve their follow-up rates by doing something like using apps, WhatsApp reminders, and so on. They are not going to work. What is going to work is parent empowerment. They have to know why they're coming back for follow-up. It should be their necessity, not yours. I always give an example that our own unit had an observer coming, a doctor coming in, and she asked me, "Sir, why are we doing more than one follow-up of the vision? We saw last week, again we are seeing this week also." A mother who was standing behind me said, "Dr. Sahab, we are doing this to see whether retinal vessels have grown completely or not. Only after the retinal vessels have grown till the end, my baby will be safe." The observer doctor almost got shocked. She said, "How does the mother know so much?" So we had taken a class for them. That a picture, we just showed these photographs showing that this is what we don't want to see in your baby. If it bleeds, vision will be gone. Therefore, the time of checkup given by your eye specialist must be adhered to completely. So there are times when they come to the OPD, I forget that an ROP was pending. They will remind me, "Today doctor was our ROP date." So empowerment and education of family is the only way forward to improve follow-up. You can see for hearing screening, many parents stop at OE and they don't want to do NVERA sometimes because you tell them sedation is required. We have to educate them why we are doing the BERA and what would be the values which would be abnormal, because many times they may go back with a report to a senior pediatrician like us who may not be doing NICU care, may not have seen many BERA reports and may not be able to guide them clearly. So it's written clearly that if it is more than 35 decibel that you required to produce a BERA wave, we need to see you again. So I'll be showing at the end of this presentation a blue book which has all these things from beginning to end. And that blue book will help you to follow up without making mistakes. If you just send me an email on this, I can send you a soft PDF copy of the blue book. And what you can do is that you can just change the front page from KIMS, where I work, to the hospital where you work. You can adapt the content. There may be some things which we do and you may be doing differently, but it has one page for ROP. The eye specialist has to write there, one page for hearing, one page for neurological examination, one page for a neuro examination and imaging, and this goes on till 6 years. So from birth to 6 years, the baby would have his progress card. The immunization is also in that book. So whether they come to you or go anywhere in the world, the family would be able to tell the doctor, "Look, my baby is special. He had required more care. These are the previous observations, and these are what we require to do." You have no copyright requirements on this book. You can just use it as your own. The idea is to spread safe practices. Now we'll come back to what we will do after we discharge the baby from ICU. How do I follow up this baby? Most often follow-up is happening, but because of the so many milestones we studied in our school, in our MBBS, in pediatrics, it is so confusing. We get upset. इतने सारे milestone हैं, क्या क्या याद रखें? What all I will remember? So please remember that a very simple model called Development Observation Card was developed by my teacher, Dr. M.K.C. Nair, and it is very easy to help practice in office in OPD settings. Remember only 4 milestones. At 2 months, baby should smile, have a social smile. At 4 months, he should sit with a straight back when held up like this, with head control being good. At 8 months, he sits like this. And at 12 months, he can stand momentarily. We'll come back to this in detail. So the mantra is 2, 4, 8, and 12. This is all you have to remember to follow up a baby. Remember to correct for prematurity. If the baby was born at 30 weeks, then only at 40 weeks you start counting as 0. Otherwise, you may overestimate his age and you may think the baby is delayed in development. So 2 months smile, 4 months head control, 8 months sit, and 12 months stand. Make sure each visit the baby has good vision and good hearing, because these are the sources through which baby gets his information and has development. At 2 months, social smile is definitely required. There is no reassuring the family if baby has not smiled by 8 weeks of corrected age. It is always a problem. You may have to check for vision. You may have to check for global developmental delay. And there may be other reasons like hypothyroidism. So see, this is what is social smile. You can see how keenly the baby is focusing into the mother and the mother into the baby, and the baby is talking to the baby through a smile. This has to happen by 6 to 8 weeks and should not be told कि देखते हैं, we will follow up. It's not acceptable. Some important motor signs are there. Although we have been taught a lot of angles called Amyl Tyson angle and whatnot, please remember that today in world of science, in world of evidence, people have started asking questions. And very clear systematic reviews were done to find out two things. Is this motor examination that we do for tone having predictive ability? That means if I say it is normal, does the baby remain okay? If I say abnormal, does the baby become bad? Second is interoperability. If I, Dr. Pankaj, or I, we examine the baby, almost each time we should get the same findings. So we had three signs which are thought to be very useful. One is the adductor angle, pull to sit, and ventral suspension. I will be showing you all these. So here you can see in ventral suspension in babies only less than 3 months old. After that, it is cruel to put a baby like that. So the baby is placed in ventral suspension, and you can see that a good baby would lift his head, keep his back straight, and lift and move his hands and legs like this. This is a good ventral suspension. Whereas a baby who has motor abnormalities, tone abnormalities, he would have his back like this, rounded. The hands and legs would just fall and they would not be moving, and the baby would never lift his head. So this is very bad sign. When it comes to head lag in pull to sit, you hold the baby from ideally from the behind the shoulder, although it's described as lift from the wrist, but then you can't support the head if it is falling back. You try to lift, and even a newly born baby, 1 day old, will transiently try to lift the head like this. A baby whose head lies like this with no attempt to lift at all is again a very severe concern for cerebral palsy. Adductor angle. This is how you examine. You have to place both the fingers on the knee and the leg like this and try to abduct. Is not the baby should be calm, should be alert. At that time, mostly angle would be clearly more than 90 degrees. You don't have to buy a goniometer which measures angle from Amazon. We all have that notebook. You just place, each notebook has an angle on the 90-degree angle. Or notebook you can just place between the legs, and if it is not wider than the notebook's 90-degree angle at any age, the baby is in trouble. Especially a preterm baby should have a better tone than 90 degrees by the time he's term age. If it is less than 90, so I'm repeating, these are the three signs we all need to examine in young infants. Adductor angle I showed you last should not be less than 90 degrees. Pull to sit should not have a persistent head lag, and ventral suspension baby should lift the head, keep the back, and dangle his legs. Very, very fantastic thing because they don't trust, but it requires a lot of training to differentiate a term. From that thing called as newborn examination and infant examination. They have borrowed from the GMA, general movement assessment, and when you see movements, you have to see two things. Are there good fluent movements of hands and legs which are variable? This time this hand, next which are having jitteriness even before you touch the baby, and jitteriness that continues after you touch the baby. So jitteriness and tremor which starts before a stimulus and continues after and moves the same kind is of twins. one baby had a very strong pose, and I think you won't have difficulty in guessing which baby had. On the right side of our screen, you can see a baby who has good quantity of movements, rich movements, left hand, right hand, legs separately moving, whereas the previous baby on the left side has decreased quantity of movements, and also the range of movements is much lesser than the baby on the right side. So developmental outcome can be predicted easily by this too. So summarizing at 2 months, what will I do? At 2 months, I will look for social smile. If it is not there, there is nothing telling the family, please wait. No. Test. Ventral suspension, pull to sit, and adductor angle. And movements should don't get this, what do I do? Then examine the baby again after 2 weeks. Persistence of signs. Most of
Sir, your voice
development.
is
Persistent signs. It's
sir,
going away.
Dr. Naveen, sir.
Are you
Your
able to hear me
voice is
now?
breaking, sir. Your voice is breaking.
Oh, I'm sorry.
Maybe you'll off
Is
your video for
it
some
any
time.
better now? Okay,
Yes, sir.
I'll do that.
Hello. Naveen, sir?
Is it better now?
Yes, sir. It's better.
Okay.
Sir, last slide, please. Can you start with last slide? People
Yes,
were
I can.
asking about jitteriness and
So, yes. So if you see a baby having jitteriness, which starts even before you stimulate the baby, like uncovering the baby, touch most babies. Before you give a stimulus and persists after the stimulus goes away. Like a tremor or jitteriness, you go to the NICU, you see the baby in OPD, and he's saying jitteriness continuously. It is persisting even after the stimulus goes away. It is a real concern. It has very high predictability for abnormal development. So a jitteriness or a tremor should not be there before the stimulus and should disappear after the stimulus has gone away. You should be able to console the baby and stop all these things. Now, if you find a baby having one of these signs, a delayed social smile, motor abnormalities, any of these, then you would quickly examine the baby within 1 to 2 weeks. If the abnormal signs are still persisting, then it is a main concern. If you have two signs, for example, a small head circumference also, it makes it even more worrying. The risk becomes exponential. And if there is an existing risk setting, I will just show you an example. If a baby had severe asphyxia at birth, required extensive resuscitation, also has poor head growth, and now having severe head lag. This is called as combination signs in the presence of risk setting. This is called a PCR of development. Then the baby has very high risk of developmental problem. If all are green, in spite of severe asphyxia, baby has good head growth and no abnormal clinical signs, baby does not require an MRI or neurology reference immediately. This baby has better risk, better outcome. Mamta, is it clear now?
yes, sir. It's clear.
Yeah. Now we go to the second milestone, which is the 4 months development. Before that, remember that in young infancy, a lot of non-specific clinical signs may point out to developmental problems. Parents may come and say the baby is crying always. ask them, is the baby disturbing more in the day or more in the night? Some parents will say, oh, in the daytime he sleeps when I am awake, and night when I want to sleep, baby is cranky. This is good because baby is able to find that rhythm, which is in utero rhythm. In utero, babies are finding night for last 9 months. So when it becomes night, they become active, they will cry, they will feed, they will pass motion, urine, and the cycle will go on. In the daytime, they don't like the light and sound near them, and they would continue to sleep. So if the baby can perceive this pattern, he is a healthy baby. Similarly, if you ask them, does the baby settle down when you hold the baby in hand, consolable, cuddleable? It is very good. But a baby who can't be consoled, if medical problems are excluded, like hunger, dilution of feed, and so on, then it is a developmental concern. A baby who coughs or gags during feeding is also a worry. And a baby who you must ask the mother in a preterm baby when he is given milk, does he finish quickly? Or when he's at the breast, does he suck at least 8 to 10 times without coughing, without gagging? If that happens, baby is safe. A baby who gags and coughs during feeding, he becomes tired and lethargic after feed, is a worry. And similarly, if sleep rhythms are not there, even one event of life-threatening choking should bring a risk of developmental problems to attention. Now coming to 4 month signs. In the 4 month signs, a baby should sit like the green picture you see, with a straight back, head should be straight like that, like the picture on the left side. See this video? You can see that the baby is very keen, sitting straight, and has the head straight in midline. Whereas the baby on my right side, that baby is completely lazy, straight back is not maintained, head is still to one side, and see the lack of keenness. He is not too interested in making eye contact with me. So very easy to pick up at 4 months vaccination visit. When I say 4 months, it can be 3.5, it can be 4.5. But baby should sit with a straight back. Head should neither tilt to side, nor forward, nor backward. It should not be a rounded back like I show in this red picture on the right side. Baby should be trying to catch everything. 4 months is the age for catching. Catch objects that are placed in his hand. Hand should be open like this and catch your object with his eyes, catch the object with his sound. By the time he should be able to turn around and find the source of sound. He should keenly track and try to pick up everything in the room. So at 4 months, head control is very good, except when mother moves rapidly, there should be no wobbling. He should track well and turn to sound. So catching everything at 4 months, catch an object, catch with eyes, catch with ears. In fact, I had a baby on follow-up with skeletal dysplasia. He had no hands, but he tries to catch very keenly with his eyes and tries to see what is happening. At 4 months, baby rolls over, and both ATNR and Moro should disappear actually by 1.5 to 2 months itself. So if a parent says the baby has not rolled over at 4 months, the first thing you have to do is check whether ATNR Moro have gone away. ATNR is meant to prevent the baby from falling. So if the baby, when head is turned to one side, the arms go straight and tries to prevent the baby from falling, then at 4 months, this baby is abnormal. He has to go to a neurologist. This ATNR ideally should go away by 2.5 months last. And similarly, Moros is holding the baby and dropping the head in relation to the back plane. So the plane of the head should fall in relation to the plane of the back. Just like when a monkey jumps from a tree to tree and the baby monkey gets whiplash like this, head going back. So then Moro should not come beyond 1.5 to 2 months. In fact, Moro is not useful in doing in the first 1 or 2 months of life. It is useful only after that because the persistence of Moro is an abnormality. Hand should be open all the time, not like this baby. Even in newborn period, hand should not be fisted and kept always like this. Baby should open the hands, try to move. This is a good sign. So what are high risk of CP? Now the word CP has been replaced by a term called high risk of CP. By 5 months, you should be able to make a diagnosis. Then only an early intervention can start. There should be good head control by 4 months. straight back. Baby should roll. They should not be having any Moro or ATNR. Hand use should be very good. Tone abnormality should not be there. You should not have a small head, and risk settings will guide you whether you need to see closely. When you do a knee jerk, it is not the size of the jump of the leg. It is the place, how far you can elicit the knee jerk. If you can elicit the knee jerk from the ankle, then it is abnormal. Normally, you would do it at the patella. But even by hitting the shin or the ankle, if knee jerk, this is called spread of this area of elicitation. And if you have an adductor spread, when you do the knee jerk on one side, the other knee gets adducted and comes towards your knee. These both are abnormal. So at 4 months, baby should track well. So at 4 months, the baby should track well. You can see how keenly he is looking at that toy and how keenly this baby is looking at me. So 4 months, tracking well and turning to sound is important. If not, then you have to start looking whether hearing problems are there. So if baby is alert, these are called insurance factors by Dr. Illingworth. A baby who is alert, keen, tries to catch things, looks around in your room, looks at the fan, light, this baby has no global developmental delay. His vision is good and there is no motor control problems, no cerebral palsy. So head should be steady. Baby should hold objects with hands open and look and turn around by 4 months. So we are summarizing only 2 months and 4 months milestones. At 2 months, social smile, lift head with no head lag and good quantity and quality of movements. At 4 months, baby tracks and turns to sound, head control, rolls over and has a very good hand use. So we learned, what did we learn today? I'm almost summing up and closing for you. Some babies have risk factors. We should have a checklist inside the NICU also what to do, when to give breast milk, when to do ROP screening. You should have a pre-discharge checklist so that you don't miss anything in communicating to the family. Integrate with medical follow-up. This is the most important. Development pediatrician is a separate person. No, you are the developmental pediatrician. Along with immunization visit, you must check. And there is no need for great tests like Bailey scale for helping babies. It is good for research, but for helping babies, 2, 4, 8, 12 is all that you need. So if you want to be a safe doctor, your baby has to be safe. Flag the babies, give them a special book. I will show you blue book quickly after this. Document the risk factors and the severity. Checklist for follow-up should be ticked off. Schedule follow-up till school entry. Educate parents why they need to come for follow-up. Track head growth. Milestone check 2 months smile, 4 months head control, 8 months sit, and 12 months stand. And persistence of signs, combination signs in the presence of risk settings. PCR of development indicates baby has a major problem. So I'm stopping to share. I'll just show one more document. Just give me a minute. So just coming back to you. This is called our blue book, and I'll be very. Are you able to see it, sir? So
Yes,
I'll just
sir.
scroll down the blue book. We have it. Our gynec department marks the risk factors antenatally. Here we record the parent details. Then we have the risk assignment. Some of the risk factors I had not shown you. We have a growth chart and NICU checklist, all the lab reports, imaging reports, pre-discharge checklist, neurological examination tool, hearing chart. So the audiology report will be marked here. It will be with the parents. They'll bring it to OPD each time. Visual assessment, and then each age, 4 months, 8 months, 12 months, and this goes on till 6 years. In the same book, we also have a composite at the end. Development assessment is not enough. You have to mention whether you need a referral and what was the feedback from the specialist. You also have the growth charts for older age. And most importantly, the vaccination book is also in the same chart. Medical risk factors which are commoner like hernia, undersyndesthesis, regurgitation, all these also are mentioned so that even a young resident who is not exposed and is working for you will not miss anything. Thank you for spending your Sunday with us. And if any questions I can try. Apologies if there was poor internet in between. I was taking rounds in the hospital and Maybe the internet was breaking there. Over to you, sir.
I think, thank you so much, sir, for an excellent. I think the most simple, somebody is talking, follow up in the simplest way and showing the some simple signs to pick up early developmental delay. And I feel that's the very important step, because most of the time in a busy OPD, when you see even the follow up of some other unit, you miss if you will not know these important signs. So I thank you, sir, for an excellent talk. And I request everyone to please share their questions for the. So, sir, the hearing part, I want to ask you. So we are doing OE at discharge, and if it fails, we again. So do you say, as per the new guidelines, I think by 3 months they should have gone for the BARA, or the screening BARA is okay? What do you suggest, sir?
Yeah. All NICU babies must have a BERA because OE is testing only till cochlea, whereas the problems of asphyxia, hypoglycemia, jaundice, sepsis, all are affecting brain and nerves. And a baby with abnormality in the auditory nerve or brain will pass OE, but may have problems with BERA. So mandatory, you may not have it in your hospital. Please identify a place where they can go. लोग कहाँ कहाँ नहीं जाते क्रिकेट मैच देखने के लिए अफ्रीका जाते तो people will go. You have to tell them. And people are scared about the word sedation or taking half to 1 hour. You have to explain to them why it is so critical that both ears need to be tested separately. You have to test for 10 decibel, 20 decibel, so the baby can hear in a loud, noisy room like this, and also high pitch and low pitch sounds. These cannot be tested by just door banging, child responding to call. That is not enough. So an NICU baby should be offered, and if you educate them clearly, the uptake of BERA will be much higher.
So are there any intervention protocols for such babies so that even if you don't detect any problems or minimal problems, so that the parents can do at home and so that they can stimulate the baby? And
Absolutely, sir. There is a very clear early intervention protocol available. In India, Dr. MKC has written a book called Early Intervention. People can look at that. And part of it has been included in both the Illingworth and the Cloherty also. But very simple things include that parents must spend enough time, not after discharge from an ICU. From first day of admission in ICU. In our unit, even a 26-weeker intubated, parents are asked to come, touch, and talk to the baby. And there is enough science. If the topic was on early development milestones, we could show you there's enough science to prove that babies, when they started touching the baby and talking to the baby in the NICU, their adult language development was far richer. जो अभिमन्यु की कहानी हमने सुनी है वो गलत नहीं.
so do you practice kangaroo mother care also in your
Yes.
NICU, and especially for such babies?
Not only kangaroo care, even when a baby is very sick and maybe on inotropes, tube, whatever it may be, then also the tube feeding is given by the mother. The father is holding the baby because they have to touch the baby, then only baby will heal. Not only there is endorphin release, there is increase in breast milk, and for all the young people who think talking about breast milk is a BPNI thing or it is a community medicine thing, ऐसा नहीं है. जो regenerative cells brain में हैं, जो breast milk में है, what is there? Stem cell therapy you want to give. That is stem cell therapy only. They have shown that when you give breast milk, babies had recovery of brain development. So, but that mother has to give breast milk from day 1, day 2. So we ask parents to buy a breast pump as soon as baby is in the ICU. Start pumping. We tell term baby should breastfeed from 1 hour. Preterm baby को 3 महीने के बाद क्यों है? Why after 3 months? He should be simulated sucking and pumping. So we have a breast pump in the labor room, and they would start pumping from birth.
And I think kangaroo
Sir,
care,
Dr.
if mother is not there, the father or any caregiver can come
Yes.
and give. Yeah,
Yes,
that's very
yes.
important.
So Dr.
Timing
Prerna
of
has
starting,
asked
yeah,
any minimum gestational age at which OAE can be done, and
both,
where at what time?
yeah, both OE and BERA, we in preterm babies, we try to do before we discharge from the NICU. Because after that, they may not come back. If your hospital has an ABER automated BERA inside the same OE machine, then it gets over there itself. But if it is not available, then you can have a BERA in the audiology lab. By around 3 months, we are able to do it because sedation is only pedicloral, nothing more is required, and keeping the baby calm. So we ask the babies to be fed just before the procedure is done because it does not require any innovation at all. It just requires the baby to remain calm when earphones are there and there are electrodes recording the signals.
Yes, sir. Dr. Garima is also asking that with sedation to be used for BARA and MRI.
In BERA, we are using pedicloral because the babies are 3 months by that time. If it is a newborn MRI, we require no sedation. World over, they have stopped sedating these babies. Just what is called as good wrapping the baby. 80% MRI we are able to do in newborn. But if it becomes 2 months, 3 months old, then pedicloral will be required.
So can you please share the PDF of these charts so that we can share with the delegates?
Yes, sir. I have already sent the email ID. I'll type it in the group again. But in
So
addition to
please
that,
share in the faculty group. We'll share with the
I
delegates.
will. Done, sir. It will be
Thank
done, sir. And in fact, we want them to use it. We are very happy if they share it with their friends. They do not have to acknowledge the hospital where I work. They do not have to acknowledge me. They have to only use it because nothing is original. We have an ROP chart. We have what we are trying to do, just organize the content, just say we will not miss anything.
We welcome Dr. Bhandari, sir. Welcome, Dr. Bhandari, President IIP Delhi.
Welcome, sir. So
Ma'am,
for
you
the
were saying
next
something.
question, yeah, so for the next question, Dr. Sudhir is asking that do we need to do BARA for IUGR babies also?
If the baby required ICU care for more than 5 days, then it is best. This is just a guideline, but IUGR babies may be the ones who have an IU infection. They may have a genetic problem which is not visible to you. So if it is not an SGA, lot of babies in India are SGA. They are not IUGR. They're just small families. They may not, but if the baby has not achieved full growth potential, then I think it's best to do it on.
So, sir, I want to ask something.
BERA is only done if they fail in the OE or otherwise in all the babies?
No, sir, it is not sequential for NICU babies. NICU babies should have BERA even if they pass the OE. Because OE is testing only till cochlea. Whereas all neonatology problems are happening beyond that. Premature brain, it is brain, not cochlea. Jaundice, hypoglycemia, asphyxia, meningitis, amikacin, everything.
Dr. Sudhir has asked, why do we do BERA? So just to remind him, this is just to test the central nervous system hearing.
Yes. And some of the babies who are IUGR, fetal growth restricted, they might have had a medical problem antenatally, which may be causing them to grow so small. So it is best to be safe and do one examination.
Sir, for early stimulation therapy to start, especially in the very preemies baby, so what should be the right corrected gestational age where we can start with the early stimulation? Is it at the time of discharge, we can tell them like if it is 32, 33 weeker, or it's at least 36 plus?
Day one, and I'm not exaggerating. It is not exaggeration. And there are a lot of programs world over like NIDCAP and things like that, but I think they are overrated. I'm not rude, I'm not being unkind to any program who is being done. एक माँ बाप को, you don't have to teach a mother and father how to stimulate the baby. You just bring them inside and you ask them to stand near the baby. First day they are scared. They have not seen a baby with so many tubes. Second day they will start touching, holding the hands of the baby. They will start talking to the baby. When you switch on the light, they cover the baby like this. जो हमें याद नहीं था, we don't remember. And they will start touching the baby gently. We will turn the baby like this. So they will do exactly what a baby has to have. The parents are the best DSC nurse. And it has to start on day one, day two, as soon as the parent can walk to the NICU. We have 24-hour access to all parents in our NICU.
So,
I request
another
Dr.
thing,
Bandari sir to say,
yes.
say
Oh,
something.
It's been a really enlightening talk, and as usual, as per the trademark of Dr. Naveen Jain, we are really thankful to enriching our audience with your experience and the great insights into the topic. Very well covered, very penetrating and in-depth knowledge you have spread. I'm thankful to you, sir. Delhi IAP thanks you, and Dr. Mamta also for sparing time this Sunday morning.
Thank you, sir.
And
Thank you.
and I will request all the friends who are there as participants that somehow people are feeling they can see the recording later on and they need not join it. Please spread this message that live show has got a different meaning than a recording. So, and plus the question answer session and the discussion, the lively interaction, that is not possible in the recordings. So please, thank you, Ajay. Carry on, please.
Yes, thank you. Dr. Mamta, please go ahead.
Yes, sir, one more thing. So I've seen in my practice that there are many times the people are getting a CT scan of neonates done. So are there any specific indication other than bleed which we can pick up from the ultrasound also to do the CT scan, or is worth to do MRI if it is and we are thinking that the baby is developmentally delayed by 3 months of age, or what could be like, because at the time of birth or within 7 days, is there any role of CT scan or MRI to do?
There is possibly only one indication for CT scan. If a baby is in the ICU, let us say ventilated, and you are thinking that he has a subdural hemorrhage. So he has a drop in hemoglobin, he is shocky, and he's bulging fontanelle, drowsy, and you think a neurosurgeon has to put a burr hole. A CT takes only 10 minutes, and the baby need not be made unstable. MRI may take longer. In all other indications, CT has no role. It has to be ultrasound first in a preterm baby, and we do very few MRIs also. Unless you must ask one question at the end of the MRI. If I find this, what am I going to do? Even if you find PVL, what are you going to do? You're only going to do developmental intervention. So don't do a MRI just to confirm, to make a documentation. It does not help anybody. In fact, if you have to do only one MRI, save it for later when you have more information to be acquired. So if you have to do an MRI, you must have a note written in your mind, in your notebook, that if I find this MRI finding, then I'm going to do this. If I don't find this, I'm going to do this. If you can't find these two answers, there is no indication.
Are there any restrictions on immunization about the gestational age and weight?
By the age of 34 weeks post-menstrual age, we are immunizing babies with BCG, OPV, hepatitis B. In fact, I would invite all of you to read the chapter which your own guru, Dr. Arun Wadhwa sir, has written in Guwahati. This chapter was never there in any book, even internationally, on newborn vaccination for preterm. And beyond 6 to 8 weeks, even a 30-weeker can be vaccinated. So there is no restriction to vaccination except for oral polio and rota drops not being given inside the ICU because of the risk of spreading it to other babies.
If we diagnose that baby is going to have a developmental delay or is the early risk for CP, or by 3 months, if we feel, do we need to send them to developmental neurologist, or can we do it like we can do with the occupational therapy and the sensory integration? The neonatologist can do or a pediatrician can do? Because the developmental pediatrics is the new upcoming thing which is coming very.
Yes, ma'am. Pediatrician, developmental therapist, and pediatrician should be a center of all care. Neonatologist should be a center of care because he knows what has been done in the ICU. But they should refer and get the baby back to them. It is not for your business. It is because what ophthalmologist knows is only about the eye. Audiologist, but the baby has the whole body and has many care issues. We have seen babies who have gone away only to special developmental services, and simple things like anemia get missed, thyroid get missed, and these problems. So the center of all follow-up should remain the pediatrician or neonatologist. They should cross-refer and get back the information and integrate into their care.
how frequently neuroimaging is to be done? Somebody, Dr. Karthik Nair is asking.
In preterm babies, we do it twice. First one is before 2 weeks of age, and second one is at 36 weeks post-menstrual age. MRI we do only if really indicated. We are not doing possibly more than 3 MRIs in a year.
Dr. Nilima is asking ROP for exactly which babies? I think ROP protocols are, but sir can answer that. ROP for which
Yeah.
babies?
I
Maybe
think
we
all
can share
preterm
the
babies less
guidelines
than
in the
30.
group.
Absolutely, sir. I agree
Maybe
with
we
that.
can share the guidelines in the group.
ROP is done.
Done, sir.
And Dr. Jim is asking, can you talk more about cortical thumb?
Cortical thumb is one where there is an imbalance between adductor and abductor movements. So abductors are not there, adductors are there. And this is happening for a very long time, then only you will get this fixed thumb. Sometimes it will be seen through like this. It is an indication that the brain development is severely affected. But make a diagnosis only if there are other such the babies will have microcephaly, severe delay, seizures. Just by seeing this thumb, don't make, because you may mistake a baby with a closed fist as adductor thumb. So adductor thumb is there only in a baby with severe global developmental problems.
So Dr. Rajni is asking if a patient comes at 4 years of age with developmental delay and there is history of delayed cry, but no radio imaging till now done because of negligence, what to do? Treat that patient.
At 2 years of age, neuroimaging by ultrasound may not be possible because the anterior fontanelle would have closed. And at that age, your focus of attention is not ventricle. You may want to see other cortical areas of development. Simple indication for MRI is if there is microcephaly, macrocephaly, or a unexplained developmental delay. So if there is microcephaly, macrocephaly, he must have an MRI. If there is unexplained global developmental delay, if there is a clear history of asphyxia, clear hypoglycemia, you may not add value.
Dr.
You
Prerna
mean to
is
say we need to do an MRI and do the developmental screening? Like the child has to be with a developmental specialist, and we can get
Yes,
a
sir.
MRI done inside.
Sure.
Sir, Dr. Prerna is asking that she had a baby in NICU with TTNB and had 2 brief episodes of seizures noted by a nurse. Lab reports normal, USG brain was also normal. So should this baby have further imaging in follow-up if development is normal? I think no.
Only if the baby has 2 clinical concerns. One is a head circumference which is not tracking, or the neurological examination is abnormal when they come in follow. Otherwise, routine imaging is not required.
Maybe baby will need a regular follow-up.
Yes, sir.
And why is it that we are not supposed to immunize infants when they are in NICU? Dr. Manuja,
They
we
can be
can-
immunized except for oral polio vaccines and rota vaccines, which are live vaccines and may spread to babies who are much more immature in the NICU. But all other vaccines can be given.
parents worried about asymmetrical head shape sometimes. How to counsel?
If there is plagiocephaly in preterm baby, it is very common. And that also adds problems in measuring head circumference. But if the baby is having plagiocephaly, you try to put a towel around the head U shape during the examination so the head is in midline, and then look for asymmetry in the baby's hand and leg movements. If it is there, then they need to see a neurologist. But I would say that in 1 year, I see only one baby who has problem. Others have only positional plagiocephaly. When 4 months and 5 months, when they start rolling, this would return to shape.
I think sometimes the parents miss the follow-up visits. I think it's very important to emphasize all the follow visits because child may be missing on the ROP or and developmental screening, etc. Because there can be very subtle signs which can be picked up early and intervention can be done. Especially the ROP, if the parents are not visiting, we must send them reminders. Like otherwise, nowadays the courts are very, very, there are too many medical legal issues arising out of our ROP. So we should keep a record of that we have tried to remind and they didn't visit.
So there has to be, in addition to what you said, initially in the NICU itself, education. Why we are doing it? not when you need to come, why we are doing it. So they should know that vision can get affected and it can't be done another date. Tab tak bleeding ho gaya, so you cannot come back later on. It is too late. Secondly is documentation. That blue book you're giving in their hand, and on that blue book you have written like vaccination card. These are the dates till 6 years. You give dates before discharge. Then it is participation of both. Both are responsible for misfollow-up, not just you. Otherwise, if you do not document, then you are responsible alone.
I
So
think
if
it's
there are
very
no more
important
questions,
very important to have like early recognition of all the high risk factors. And that's the talk sir has given is very beautiful. That he has started with the red book and the blue book to jot down the risk factors initially and then follow them accordingly. So I think it's a very beautiful, very simple, and very exhaustive session. So for the all pediatrician to do, sir. And I want to emphasize one more thing that every visit head circumference should be taken. Because I have seen even in our OPDs when the residents are sitting and it's a quite heavy government hospital, but they don't want to take the head circumference. But I feel that every newborn who is coming for the follow-up, the head circumference should be taken and it will be noted in that. Even if you can't take length, it's okay, but head circumference can't be missed on your follow-up visits. That has to be very.
I think there should be a checklist which is attached with every OPD slip that residents or we also as practitioners should be ticking on those checklist boxes.
It's
Because
clear,
that
but
will so that we do not miss on anything. Because sometimes busy OPD we may forget, but if there is a checklist, we are supposed to tick all the boxes.
So somebody asked that 2-year-old child and ICU stayed 2 months. And OE done, but BARA was never done. So can we do now?
Ideally before 6 months, but it's never late. Even after that, it can be done.
I think there are no more questions, sir.
Thank you, Dr. Naveen, sir, for your wonderful presentation and discussion. And I also thank Dr. Mamta Jaju for coordinating and chairing this session. Dr. Mamta Jaju is organizing NEOCON. Would you like to say something about that NEOCON and invite the delegates?
Yeah, we are organizing North Zone NEOCON on 27th and 28th July at Delhi. So I request all the PGs and fellows to register for the workshops. We are holding around 9 workshops, and the esteemed faculty for the workshops are coming from all over India. And I also want to request them to register for the conference if that will be done. Thank you so much. Thank you, sir.
And in that line only, I will also announce that we are having Pediatric Conference of North India and flagship program of Indian Academy of Pediatrics Delhi on 21st and 22nd September at Hotel Hyatt Centric Janakpuri, preceded by workshops on 20th September and 15th September. So please register for that also. Visit Delhi IAP website.
Thank you. So on behalf of IIP Delhi, I thank all the faculty and Dr. Alok and all the delegates for joining in. So we'll be seeing you all next Sunday at 9 o'clock. Please join. Thank you so much.